The patient is 43-year-old. He presented with an incidentally found aneurysm on workup for headache. The patient did not notice any episodes of sudden severe headache or neck pain. Neurological examination, intact. A history of arterial hypertension, long-term smoking. CT angiogram shows a large basilar bifurcation aneurysm with wide neck. Both P1 segment is in the neck of this larger aneurysm. We perform modified orbit-ozygomatic craniotomy. Here is an intraoperative view. I am opening of the arachnoidal cisterns over the chiasm. Next, to expose the retrocarotid space, we dissect the Lillequist membrane. Third nerve also visualized. Partial subpial resection of the oncus of the temporal lobe is performed. The edge of the tentorium is visualized. Here we see the interpeduncular space. A large aneurysm of the basilar apex is visible. Critical perforating arteries are stretched on the dome of the aneurysm. To increase the retrocarotid space and the freedom of surgical manipulation, the posterior communicating artery is coagulated and divided near P1 segment on posterior cerebral artery. Next, sharp dissection of the arachnoid near the neck and the dome of the aneurysm is performed. Additionally, posterior clinoid is partially resected with 3 mm diamond burr. Venous bleeding can be controlled using wax or other hemostatic adhesive materials. In this case, wax was used. The next stage is a direct visualization and dissection of the critical thalamo-perforating arteries that are stretched on the dome of the aneurysm. All actions should be aimed to preventing damage to these critical perforating arteries, as this can lead to severe ischemic damage of the thalamus. P1 segment is visualized from the opposite side of the posterior cerebral artery. A clip is planned to be applied. The neck area is examined. A temporary clip is applied to the trunk of the basilar artery. A temporary clip is applied to the AP1 segment of the posterior cerebral artery from the opposite side. Dissection of the aneurysm neck and clipping with a curved clip is performed. Clipping should be performed only after evaluating the course of the perforating arteries. An additional clip is applied. Next, temporary clips are removed from the trunk of the basilar artery, and blood flow is restored. The total time of temporary clipping in this situation did not exceed 4 minutes. Additional dissection of thalamo-perforating arteries is carried out. Here we see that aneurysm is still alive, which required additional clips to be applied. Again, during visual inspection, with an assessment of the course of the perforating arteries, an additional direct clip is applied to the aneurysm sac. A reinspection is carried out, excluding stenosis or damaging of the perforating arteries. The situation requires the application of a clip to completely close the aneurysm sac. When trying to remove the clip from the dome of the aneurysm, it's enlarging and bleeding occurs. To completely eliminate the aneurysm, another straight clip is applied. CT angiogram shows good clipping of the aneurysm. Postoperatively, dysfunction of the oculomotor nerve occurs. Dysfunction restored after 2 months after surgery.